Okay, so welcome everybody to the Council of Governors meeting in public, the January meeting. Happy New Year to everybody. It's lovely to see you all. We've got a fantastic attendance today, which is great. And I know that some of our new governors who will come into post from the 1st of February are joining us virtually as well. So welcome to them and to anybody else who is joining us virtually. Thank you very much for showing interest in our meeting. So if we could just go to item 1, which is the apologies for absence. Jenny, if you could just list them.
Gwen Lunn, Andy Barber, Jenny Brister, and there may well be John Cunnington and Christopher Duggleby as well.
Perfect, thank you very much. And then if we move on to the declarations of interest, item 2, you've got the paper there, and Jackie, I know that you've notified an additional declaration. Jackie White from the university is also the trustee of the Warren Youth Centre, so we'll make sure that gets added to the paper for next time. And thank you for letting us know. If anybody else has got anything else where they need to make or change a declaration, please let Jenny know. And if you've got anything where you need to declare a conflict or interest with anything on the agenda, please do so and then remove yourself from that item.
Sharon Duff got a hand up.
Sorry, who has, sorry?
Duff.
Duff. Sorry, Duff.
I do have 2 changes for my declarations of interest. I'm no longer part of the CCG in Hambleton, Richmondshire and Whitby, and I'm no longer involved with the rural arts. So I will write to Jenny Jones and formally let her know. Okay.
Thank you.
Great. Thanks, Duff. I think you're just trying to keep Jenny on her toes every month with a change to your declarations, Duff, actually. Thank you very much for that. So if the governors are okay with this, I'd like to move straight to our patient story. We've got Joan with us today, and I know you've got a brief introduction in the papers, but Mandy's just going to briefly introduce Joan. But I'd like to say thank you for Joan for once again giving her time and coming to tell and share her story with us. It's really important that we do hear these patient stories at the council. So Mandy, over to you.
Okay, thank you. Please can I introduce Joan? Joan cares for her husband who lives with dementia, and she's come to speak to you all today to share with you her experiences of supporting her husband with dementia and also his experiences in our services. So welcome, Joan, and once again thank you ever so much for coming to share your story.
Good afternoon. Can everybody hear me okay? Yeah, good. I'm here, as Mandy says, because of dementia. There are hundreds of us out there, all at different stages of our dementia journey, at times struggling to come to terms with our new reality. My husband is one of the most compassionate and helpful men that you could meet. The sort who stops the traffic to allow an elderly person cross the road. However, public perception of my husband changed. From "thank you, kind sir," to "go away, that man is interfering with me." The reality of our situation hit me in December 2018. Our 11-year-old granddaughter, worried because we lived alone, said to me, "Nana, do you know what to do when Grandad gets angry?" My husband was diagnosed with dementia in February 2013. However, we first noticed some memory problems in 2007. By 2009, his dementia was impacting on our quality of life. My husband's a very proud man and did not wish to be referred for support. In 2016, he agreed to us both attending a monthly Alzheimer's support group. By this time, we were isolated as a couple. Our previous very active social life had disappeared. One of the things that happens when you become a dementia family. We first entered the care of Humber Teaching NHS Foundation Trust in 2018 into the community mental health team in Beverley. Although back in 2013, we were part of a control group researching cognitive behaviour therapy and dementia. During August 2018, while out shopping with my husband, there were a number of incidents. Thankfully, we were in a dementia-aware retailers and staff were able to support us. When I got home, I contacted the GP who met with us both. I requested an urgent referral for psychiatric reassessment. The GP contacted mental health services and attached 2 A4 sheets of care notes written by myself raising behaviours of concern. The GP followed up on his referral to mental health services on at least 2 occasions. It was about 6 weeks before I had contact from the CMHT. During those 6 weeks, there were a number of other difficult incidents, and it was obvious my husband was very distressed. One involved my husband refusing to come into the house one cold evening. The out-of-hours service were called for advice. Several days later, my husband was admitted to HRI with a chest infection, query pneumonia. By the time my husband was allocated a very supportive community mental health nurse, he was receiving daycare 2 days a week. On one occasion, he found his way onto the roof garden, and they had a real concern that he was going to throw himself off. I went to the day centre with some of his medication to calm him down. By the end of September, I was contacted by the statutory run day service to advise that due to his challenging behaviours, they could no longer care for my husband and he was going to have to leave. This led me to source private residential homes for support. When I visited these, it was apparent that they were not suitable to support my husband. His needs were too challenging. In November, I arranged private daycare 2 days a week at a private residential home in Hessel. By the end of January 2019, my GP was so concerned about my health, he referred me to a cardiologist. I contacted the private home to advise I desperately needed some respite and asked if my husband could take the next available bed just for 1 week before it was allocated to someone else. During this time, I received support from the CMHT with counselling and supporting me to make decisions about his long-term residential care. On the 11th of February 2019, I agreed to my husband's stay to be permanent. On Valentine's Day, following a serious incident, the private home contacted mental health services. A crisis meeting took place on 14th of February. My husband was sectioned and admitted on the 15th of February to Maester Lodge. This process worked well and was well organised. Myself, Beverley CMHT and Hessel CMHT were all involved. Once admitted to Maester Lodge, I noticed a difference within my husband. He could get agitated and aggressive. However, because he was in an environment with plenty of space, which was run by skilled staff, a lot of his agitation and unpredictable behaviours could be managed appropriately. There is a very clear traffic light assessment system within Maester Lodge, which works well. The team has weekly multidisciplinary team meetings. I had a link to the meeting through the psychologist. During my visits, I got to know the staff and they got to know me. They have a much more proactive approach. Dr. Glover and the whole staff team were absolutely terrific at keeping me involved in decision making. I understand the difficulties the team have with the speed they have to work in admitting and transferring patients. My main concern is the lack of appropriate, locally based, moved on placements for people with dementia who have challenging behaviour. We are one of the lucky few. When my husband was sectioned, there was a bed at Maester Lodge. Similarly, when the assessment period was completed, there was a bed in Castle Lodge. Many families in crisis are separated because the only resources available are out of county. As we are discovering with the COVID crisis, people with dementia need regular contact with friends and family to prevent an accelerated deterioration in their illness. At the end of May 2019, my husband was discharged to a specialist dementia unit in a residential nursing home. Gould CMHT and Maester Lodge offered extensive support to the unit. However, following a serious incident about a week after admission, the placement broke down and my husband was transferred back to Maester Lodge by ambulance at 11:30 at night. Once back in Maester Lodge, Joe was brilliant. We met early the next morning to review the care plan. The MDT concluded that my husband required a longer stay, secure hospital placement. Maester Lodge liaised with the CCG, and on the 3rd of June, he was assessed by Castle Lodge Independent Hospital. I visited the hospital and spoke to the ward manager. My husband was transferred into Castle Lodge on the 7th of June. With continued psychiatric support and a skilled nursing team, we were able to rescind the Section 3 mental health order, and he is now subject to the deprivation of liberty safeguards. I continue to be involved in his care, attending every ward round by conference call. On the 5th of January 2021, my husband was discharged to a specialist nursing home. COVID-19 impacts on every aspect of our lives at present. The staff at Castle Lodge, Castle Keep, and I have very carefully planned this move within present COVID restrictions. And together we are doing everything possible to ensure my husband settles in his new home. Delivering person-centred care, especially to people with dementia, unable to process the reasons behind change, is difficult at the best of times. I believe we are underestimating the personal cost to staff working in care homes and hospitals who are committed to delivering high standards of care in all aspects of their practice, but operating within COVID-led priorities and timescales. Once my husband was admitted to hospital, I was able to become involved in carers groups. I joined the Carers Advisory Group, where I met Mandy Dawley and found out about the work of the Patient and Carer Experience team. Mandy sent me an invitation to the next forum. Through the forum, I've become involved in a number of projects, from being part of interview panels to recruit trust staff, presenting and talking with a consultant psychiatrist to medical students. Currently, I am participating in the Trust's Community Mental Health Transformation Project, the Mental Health Inpatient Redesign Programme, and Dementia Diagnosis and Post-Diagnosis Pathway Development. This involvement has a positive impact on my own well-being, but I truly believe that the current developments will improve services and support to service users and carers in this area. Thank you for listening.
Joan, thank you so much for sharing your immensely personal and powerful story with us, and for the board members who've met you before, it was lovely to hear the update of what's happened next as well. So But also, before I take questions, Joan, I know I thanked you before, but thank you ever so much for all that you contribute to the trust. I mean, you've mentioned a few things there, but I know you give very generously of your own time and input to improve things for your own husband, for other people like him, and for their families, and it really does make a difference. So my honestly great heartfelt thank you for everything you do. So I've got some hands up already. I've got some hands up, so I'll go to Hugh Jones first, please. I think you might be on mute, Hugh.
No. Hi, Joan. Joan, just for other people to know, Joan and I know each other from a previous life, so it's. I'm sorry to have heard the length and the details of your story, but it's nice to see you. And thanks so much for sharing it. You obviously know quite services, so you're able to feel that you can commit and to provide a feedback and involvement in your husband's care. Do you think that if you didn't have that background that you have, it would have been as easy as it has been? And I use easy in inverted commas, as easy as it has been for you to be involved and contribute to care as much as you have been?
I think the answer to that is no. I mean, I had a lot of knowledge, as you know, about how things work, but I still find it confusing. I really did find it very difficult to know where to go when I needed support. And I suppose in many ways, and my husband being the person he wanted to be, I didn't ring. I went through the normal procedure that other people, ordinary members of the public, and I don't mean that the sort of interface with the public that health and social services have, and to some extent the voluntary sector. And I think I probably was quite a quiet carer. I didn't push, which you might find surprising. But I think in the longer term, it helps me advise other carers in the same position as myself about how to move forward. And I also made sure I put my husband's needs first, as opposed to me trying to change things, until we got to a situation where I could step back and allow other people support me in getting that support for him, which I think also is very important. I suppose for advice to other people about working with health and social services colleagues in the best interests of their loved ones' support, if that makes sense.
Yeah. Cheers, Joan.
Thank you. Thanks for that, Hugh. Are there any other questions or comments for Joan? Just making sure I haven't missed anybody. Oh, Michelle.
Yeah, thanks, Joan. A great story to hear again, and Happy New Year to you, and thanks for sharing. I just sort of pulled in on that really. I know we touched on this last time, but it's just about it's great to know that, you know, where things went well, but we're always obviously learning and just seeing how we can improve. Are there any sort of top tips for us that we can take away, that we could, you know, do better, help further, be more supportive? Either you, your husband, or the dementia community as a whole.
I think, and again, I'm going to limit this to what's happening locally, and it's something I mentioned earlier on. I mean, like this morning, I was involved in, Mandy will correct me, patient information, which is a partnership between the Trust and Hull University, and all the things that were missing for me when I started to have difficulties many years ago are now being developed both in that partnership with Hull University and the Trust. And it's going to link up information that will be more readily available for people like myself who are actually savvy online. You know, when you're starting to look for information. And I think that in many ways, as well as the developments within the Trust on patient inpatient and the CMHT, the primary care networks that you're developing, I think that's the way forward, Michelle. And I think I'm very pleased to be living in an area where the Trust is so, how do I say, proactive. I mean, the mental health white paper was just published yesterday. And yet a lot of the things, well, I haven't read it yet, but a lot of the things that are in there that came forward in 2018, the Trust's already taken on board and are developing on. So I think that's the positive message that I would like to say about what all the people in the room there, yourselves, are actually doing at the moment.
Okay, thanks, Jen. And again, thank you for everything that you're doing, because it's really helpful. Thank you.
That's great. And I think we've got Ros next, please.
Thanks. I was just going to ask Joan, if you had if we had a magic wand, what is the one thing you would want to see improved?
I think recognition that people with dementia are still people, and that you cannot create a label. I think we've been through this so much on general mental health, on learning disability, where we've fought for so many years for people being recognised as people. But I think in many ways, dementia is quite new to that. And there's still, I think, in the general community, you use it as an excuse, maybe not to look at the person first, but to look at the dementia. And I think that's what I would say.
I think that's a good continued challenge for all of us in the community, Joan, to be quite honest. I think it's, yeah, I think it's a fair point. And I think if I could just bring in Lynn, and Lynn just made a comment in the chat box, Joan, which you weren't being able to read about when you met us at the board meeting, something you said. So Lynn, would you just like to come in and just mention that?
Yes, thanks, Sharon. So, Joan, when you came to the board, I think I asked you the same question as to what's just been asked. You said dementia awareness and the pathways in relation to primary care were an area you felt that there could be more focus. So I just wanted to assure you that certainly I heard that loud and clear. I've passed that back, obviously, through the transformation work around community mental health teams, which is all focused, as you've said, on working with the primary care networks. So I know that's very much, I just wanted to assure you, part of the work we're doing. So that was heard loud and clear.
Okay, thank you very much.
Thanks, Lynn, that's really helpful. Well, thank you, Joan. I have to say, it's fantastic to hear again, and for you to very generously share it with us and your reflections on it as well. So I look forward to seeing you again before too long. But I mean, do feel free if you'd like to watch the rest of the meeting. But in the meantime, Joan, thank you very much again, and lovely to see you.
Yeah, I'm going to sign off now, but thanks very much for listening again, and nice to see some of you again. Okay, bye.
You too, Joan. Thank you.
Bye.
Thank you. Well, that was a great, powerful start to the meeting. So if we could come to item 3, please, the minutes of the meeting held on the 15th of October. I think they've been circulated around before. So are there any points of accuracy to start with that have not been previously raised with Jenny? Any matters arising that are not on the actions log? No, we'll take those as a true record then. Thank you very much. If we could please go to item 4, which is the actions log and matters arising. Craig, would you mind just giving us an update on the second item on that list, please?
Right. Hi everybody. Thank you. Yeah, I had a meeting, a Teams meeting with Tracy Flanagan on the 18th of December to discuss the Deloitte's report from 2019, particularly around clinical supervision. Really good, long discussion with Tracy. I think she's doing some really good work around that. Her remit seems to be more looking at the quality of supervision, the different types of supervision. I think she's got a very big job in hand. She sounds like she's doing some really, really good work. It also sounds, since the report from Deloitte in 2019, the processes have been refined. I think that was one of the points that Deloitte picked up, that it seemed like the way that we reported clinical supervision seemed to be multiple ways now, where it sounds like we've got one system now where an appointed person or an appointed manager sort of checks in the team that everybody's had the supervision and then reports back centrally. And that system also allows if that manager's off. So we've got a much more robust system in terms of sort of reliability and validity. I think the only thing that hadn't quite got there yet, and there's quite a long discussion about this, but I would also take on board that COVID's thrown everything sideways, quite understandably, was about how it's reported. Because I think we was initially going to look at staff self-reporting through ESR. I think technically that's been very difficult. COVID's put things back, and I think Tracy's still exploring how to do that. And I think there's sort of a tension and a concern that, as a member of staff, that if we rely on staff to report their own supervision, that might mean a reduction in the numbers of supervision being reported going down, and we might not have an accurate number against, I suppose, a more centralised where a manager or somebody reports it, and we could have some inaccuracies that way. So I think what we're working on at the moment is that they're going to keep with this much more robust system that does seem to be giving more reliable and valid reporting back, and maybe look at some way in the future where staff could also self-report that they've had supervision, because I think there's pros and cons with both of them. I think the one the trust is going with probably is going to get a broader view, but it would be nice if staff could report their own supervision at some point in the future. But it was very positive, possibly something to look at further in the summer once we've got through the issues of COVID. But yeah, she's doing a really good job, so I'd congratulate Tracy for the work she's doing and the update the trust is doing. But I said this is the only caveat is I think we did look early on about staff self-reporting. I'm not sure if that's possible, but you know, we shouldn't say no, maybe look at it in the future.
Thanks, Craig, for that update. Craig, is it okay if we take it off the main council actions log?
Yeah,
now?
Absolutely. Yeah, it was a really good, I mean, I felt much more secure from the information you give. And I think even just to be aware now that when Deloitte's came, I didn't realise originally we had multiple ways of recording. We've now got a single way of recording. You know, I think they're using it's like an email prompt using, I forgot what it's called. But the prompts are that all the supervision records are using the same system. So it's a unified system across the trust. So yeah, I'd be quite happy to do that. It would be nice to update in the future, but taking a step back with the realism of COVID, the impact, I think, you know, hats off to Tracy. She's doing a really good job with a very big and diverse subject. So I'm happy for that to be taken off.
Thank you very much, Craig, and thank you for giving that update to the council. Doff? You're on mute, Doff.
This isn't related to Craig's point, but it's related to the action log, which is, I don't know what SPC is.
Oh, statistical process chart. It's the charts that appear in our performance report, Doff. So it's a particular way of showing data, and we're going to do it was requested, if you might remember, a previous meeting, that we have some training for those governors that want it. So statistical process chart. Sorry, we do like our acronyms, don't we, in the NHS?
I mean, I think that I raise it at this point, but throughout the documentation, it's really patchy. So some areas people have actually said what it is they're talking about. And other areas of the documents, either I need to go and find my jargon buster, or I haven't got a clue what's being talked about.
No,
Well, I
it's,
can make that point now, then I won't make it later on.
no, that's a fair challenge, Doff. We can always improve. So we will certainly try and have another look at that. It would be helpful, Doff, actually, if you come across any examples, if you could just email me in and then we can have a look at them. But yeah, I do take the point. And as I say, apologies for that. Sometimes it's such long phrases, we shorten them for brevity and so that it doesn't take another page of a forest to put it on. But no, I take the point. So thank you for that. On a similar vein, actually, just as a bit of an update to that. So, as I say, it was requested, particularly for those who are not so familiar, I think, in maybe a formal work life, to do some little training on that. But also, I have spoken to Francis, Peter Barron and Pete Beckwith. Well, Francis has spoken to Pete Beckwith, and I've had correspondence with some of the governors. I think we're going to think about doing a sort of a basics training session on the finances and possibly the performance report as well, just for those that like to dip into them, just so that it won't be everybody's thing, but for anybody who would just like to sit down with some of the non-execs and in the finance terms, maybe Pete Beckwith, and just go through them so they know what they should be looking for and they know what things mean, just to make it as open as possible. So we are looking into that at the moment. So thanks to Francis and Pete Beckwith who are looking at the first one, which will be on the finances. Okay, so if we move on then please to item 6, which is the Chair's report. And a lot of what I'm going to say today does relate to the Council and Governors. So the first thing first is congratulations to Sam Mustafa, who's been elected the new lead governor to take effect from the 1st of February. That'll be fun, fantastic. Congratulations to you, Sam. You'll be really good in post. Lots of clapping going on there. But I'd also like to thank Hugh Jones as well, who's been lead governor for 2 years, I think it is now, Hugh, isn't it? And done a great job, and you've given very, very kindly and generously of your time, and you've contributed a lot to the trust in that role. So sorry we're losing you as lead governor, but very pleased that you've been re-elected for East Riding, so you will continue as a public governor. So congratulations to Sam, and thank you to Hugh. So just so we can formally record the results of the governor elections, which were obviously still ongoing last time we did meet. So for Whitby, congratulations to Doff, who has been re-elected unopposed. So great that we'll have you with us for another 3 years, Doff. Congratulations to Sue Cooper, and who is joining us as new governor. And I think Sue might be watching this virtually. So well done to her, and we look forward to her joining on the 1st of February. And congratulations to Hugh and John Cunnington, who've both been re-elected for public governors for East Riding. Jack Hudson's been re-elected unopposed for the staff clinical. So that's great news, Jack. We'll have you with us for another 3 years. And for the staff clinical stroke non-clinical, it was Claire Strawbridge who won that election. And for the service user carer constituency, Jean Hart was elected unopposed, and I've had a meeting with Jean, and she's already involved with lots of bits of the trust like research and patient and care experience. So I'm sure Jean will make a fantastic addition as a governor for our service user and carer constituency. It does mean we still have 3 vacancies, one for the service user carer constituency, although we do have other carers and users of our service on the governor group, and 2 for the whole public constituency. So they will go out again with next year's election, which will be round quicker than we expect it to be. So well done to all, and that's the results of the elections. And thanks to the membership team and Michelle Hughes for all the work they do in connection with that. So in terms of the governors, I've continued my meeting with individual governors and the new governors, and also the staff governors and the public governors. And I have to say all those meetings are really well attended and really useful, I think, from both perspectives. In connection with the induction, you will see that we're going to rearrange that so as many people as possible can attend. And I know that Katie sent an email around you all. And we will, of course, have our next Governor Development session, which we've just already mentioned, next month. So in terms of my chair role, since October, a lot of systems meetings, regularly held nearly every week in terms of the Humber Advisory Group, the Yorkshire and Humber Chairs meeting, Humber Coast and Vale meetings, and I'm sure that you'll see the updates about what's changing in the system, and I'm sure Michelle will probably mention a little bit of that later, but that's moving as pace, and we will be expecting a change of legislation in due course, as you all know. I did attend the really good Humber Coast and Vale Learning Disability Mental Health Annual Conference, which Michelle hosted on behalf of the system. Some fantastic speakers, and I think it was internationally attended, Michelle, wasn't it, from all over the world? So that was a really good conference. I've also continued to meet, as you would expect, with external partners and stakeholders, such as, for example, the chair of HUS and NLAG, and attended numerous, as I say, external events. Internally, Michelle's going to give us an update, as you know, on the vaccination situation as part of her Chief Exec report, so I won't mention that. But there's been a lot gone on, as usual, and not as usual, just pushing forward, even though we're in a pandemic. So just to mention a few of the things that I've personally attended since the last meeting we've held. The research conference, the fourth one, but held virtually online. It seems a long time ago now, but it is only since the last meeting. Fantastic 2 half days, and I know a lot of you did join that. Very well done virtually. The Recovery College has launched online. There's been numerous patient and carer experience groups that have continued online, and I know again a couple of you have also attended those. There's been a quality improvement week. There's been hampers for staff over Christmas, which myself and a few others also contributed to help load up. And then there was a Christmas virtual service, and it's a credit to all the staff, to Michelle, her team, and all the staff in the organisation, that so much has been able to carry on and go from strength to strength, even in the middle of this pandemic situation. So my thanks to all of them. So I could talk for ages, so I'll stop there. So are there any questions before I move on? No, thank you very much. So Michelle, if we could move to your item 7, which is the Chief Executive's report, please.
Yeah, good afternoon, everybody, and Happy New Year to everybody. Or should I say good regards for 2021. First of all, can I just start by a huge thank you to all the governors, but certainly all the staff, volunteers, service users that work with us, peer support workers, etc., in the organisation, because it is extremely difficult, challenging time that we are facing and that we have faced for an insurmountable period of time for 10 months plus. So can I just start with that and offer my thanks to staff. You've got your report there. I'm not going to get through verbatim. I'll pick out some things and then add others, and please do put questions in the box, or you can certainly ask me later. As the chair said, we have really maintained, and it's a credit to our fantastic, wonderful staff, that we've actually maintained nearly all our services throughout the first wave, second wave, and now into the third wave for this particular region, and the 3 lockdowns, albeit they've changed in relationship to face-to-face, and we'll come on to the full COVID report later. But we have actually maintained most of our services. But you'll see in my report, we have also tried to balance that with standing down some of the items that are not less important, because everything's important, but that we can stand on, just to give staff a bit of headroom. We did that in August, and we've done that over Christmas. So we've been really conscious that we've maintained our subcommittees and our governance structures, but we've tried to ease off some of the other areas as well, whilst maintaining data collections and outputs, etc. So there's just a little bit of an explanation in there, and that's been a bit of a balancing act that the executive team have done to support our wider staff. As I said, there is a full COVID report later, which Lynn will pick up, but I will touch on some of that as I go through, and I will pick up vaccines. Research, again, as the chair said, fantastic conference, but we are really punching above our weight in relationship to research, with lots of people being recruited into studies, and that's really important for the organisation, because obviously part of our values is learning and growing, and we want to do that, and we know what strides have been made in the recent months in relationship to COVID, and we're really proud to be part of that study, but also general research studies as well. So that's really important for us. Likewise, it's really important that we have been accepted to go live in shadow form for the specialist provider lead commissioner role. for those services that we've spoke about before, which is secure services, eating disorders and children and young people. So in order to facilitate that within the organisation, we've developed a commissioning committee, and I'm very pleased to announce that Peter Barron is the chair of that, supported by Pete Beckwith from an executive capacity, and we've got various other people on that committee, and that will develop over the next few months particularly. Huge piece of work there, and we will bring a lot more detail back to the governors as that progresses. Fantastic that one of our GP surgeries has been commended and shortlisted for the GP Awards, which is great, Market Wheaton, which is fantastic. And we've actually outsold ourselves in our recent flu statistics. We're carrying on with the flu campaign. We've sort of stood it down officially, but we will continue to vaccinate staff if they request it. We normally go till the end of January, beginning of February, but because of the COVID vaccines, we've truncated that, but we've still beaten our target that we did last year. So we're around about the 78% mark, which is fantastic. Staff survey has improved this year in relationship to uptake. We've had about 48% people fill that in. And we're beginning to get some initial data through, but it's not the full amount. But when we do, we will obviously present that to you. But it's really good that we've had a slight improvement. But actually, given the pandemic, that's okay. We're continuing with our recruitment work, and we're actually working now with doing some international recruitment and looking to see if we can do more international recruitment. But we have linked into the SHUSH East Riding work, but our own unbelievable work, and we've put a little bit in the report, has been fantastic. And please have a look at that. It is really good what the comms team have done in relationship to specific service areas for recruitment. And that's such a really important area for staff, and we'll continue to do that. We've almost completed our rebranding work. We are going to be launching that very, very shortly. And thank you to everybody around the table who's contributed to that. And again, that's another unique piece of work by the comms team. If we'd have gone externally for it, it would have cost us a significant amount of money, but we've managed to do that in-house. And when you see it, it is absolutely sensational. And thanks everybody. There's been a year of engagement. So it is something that I know you can argue, do we launch it in middle of a pandemic? But there's been so much engagement, and I think sometimes you just need that. There's a little bit of optimism. Now we've got some more treatments for the vaccine for COVID, and we've got the vaccine, that we just need to put that freshness into the system. So we will continue with that. Patient information portal is really great, and I've mentioned the unbelievable campaign alongside New Year, New Job. The volunteers have been fantastic. The chair touched on it. We've given out hampers over Christmas to staff at the front line. We've delivered Christmas presents to everybody, and that in conjunction with Health Stars. We couldn't have done it without them. So really well, really good job, really well done. We gave all our staff little things of chocolates as a little token, just to say thank you, Merry Christmas, and we'll continue to do that. We've been sort of supporting staff with little prezzies all the way through the year, because they are truly amazing, and we'll continue to do that in this year. I'm going to touch on a couple of things in relationship to COVID, and then I'm going to hand over to, well, it's later on in the agenda, but then I'll hand over and go on to the integrated care system. So in relationship to the two things I'm pulling out in COVID before we get to the detail is lateral flow testing. We were a pilot site to roll out the lateral flow test. This is the nasal swabbing that gives you, it's a relatively accurate picture of COVID being asymptomatic, so that's having no symptoms. So we were a pilot site, which is great, and we rolled that out. And again, our staff have really taken to that. And I would say that we've recorded thousands and thousands of results, and had about 30 people prove positive that otherwise wouldn't have done if we hadn't done the lateral flow testing. So again, that's been positive. And we're going to use all that data as a database for the centre in relationship to asymptomatic transmission. And we're going to continue with the lateral flow testing even post our vaccination campaign that we've been doing this week, because it's important that we still continue with that. So we're well into that now, and staff have really accepted and really acknowledged and taken on board the lateral flow testing. It's not for people that have got symptoms of COVID, but if you haven't, you do a swab. We do it twice a week. You record your results. If it proves that if it comes back as a positive, you go for what's called a PCR test, which is the full COVID test. And in the meantime, obviously, social isolation, etc., etc. And as I say, to get 30, it's probably slightly under what we initially presumed we would get in relationship to positive lateral flow tests. But again, a really useful tool for our management in relationship to COVID. The vaccination obviously is the main thing at the moment, and I thank the vaccination team, the pharmacists particularly, John Byrne, our medical director, who's been the SRO, and everybody that's been involved, the volunteers. There are videos. I'm sure you've seen the transformation of our lecture theatre into our vaccination centre. If you've not, please let us know. We'll send you the transformation video that shows it in action. It is a really good piece of a video to watch, and hopefully you've seen some of the comms that's come out this week. And again, we've got those. We can send those videos out which show some of our staff being vaccinated. Not literally. Don't get worried. It's not for this. It is okay for the squeamish. Because we're really proud of our vaccination centre, we actually worked with our PCN colleagues last week to help them vaccinate their vulnerable staff, because if you know, there's a strict criteria for the vaccination that's come from the JVO. I always say the JVO because it's the licensing authority, but it's not. It's the joint vehicle for licensing vaccinations. So there is a strict priority order which starts with the over 80s, frontline healthcare staff, etc. You've seen that very clearly. So we were helping with the PCNs do this, which was really helpful for us because it helped look at our flow of those pods. We've got 9 pods in the lecture theatre, all socially distanced, all managed very well, and that was great last week. And we've got great feedback from the service users that attended and the GPs themselves, and we'll continue to help and support the GP colleagues as we go through excuse me, the next couple of weeks. We started our staff campaign on Tuesday. We are now designated as a hospital hub, which is a bit of a minefield itself. But what that means is that we can now get deliveries of vaccines because it's a pull arrangement. So, we ask they pull it down to us, but you need to be registered. So that was a bit of a complicated position, but we got registered on Tuesday. So we actually started to vaccinate our high risk staff because that's our BAME population, shielding staff, etc. first. They got asked to book on first, they got priority, and then we worked through our frontline staff, etc. Though everybody is important, and we will vaccinate everybody who wants it. And up to date, I think we've vaccinated over 1,000 people. We'll continue to do that. We've got another delivery of vaccine today. We're using the Pfizer-BioNTech vaccine, and we'll continue to do that. We don't want any vaccines spare. We need to be in people's arms. So we have offered that service open to mutual support through some of our colleagues around the patch and across the bridge, and we will continue to work with others to do that. But we will vaccinate all our staff that want to, and the uptake has been really great. And the morale and everything has been really fantastic, and it works really well, very professional. So really positive in relationship to that. We will be doing the second dose for everybody at 12 weeks because I've seen the reports, I've seen the statistics. It's so important to give everybody one vaccination and then get as many done with one vaccination as possible first. So that's where we're up to with vaccines. I'm sure there might be some questions and I'll come on to those in a second, and we will pick up the full COVID report, as I've said. I have a slight breath and then I'm going to come on to the integrated care system. There is a lot happening at the moment. The integrated care system, if you remember, we were authorised as an integrated care system as Humber, Coast and Vale around about a year ago now. There is a white paper that's out in relationship to the future situation of integrated care system to really develop integrated services and commissioning. And that proposes that commissioning functions will go into the integrated care systems and then be managed by an integrated care system around place. And if you remember, we've got 7 places. And I think it might be something, Chair, that we do in a governor workshop, because we could have a bit more of an interactive discussion and a bit more detail. But suffice to say that we've responded by saying that we support that direction as an organisation, that integrated care around communities and place is the way forward. And to continue to build on the work that we've been doing in Humber, Coast and Vale, which is the 2 geographical patches that we have, which is North Yorkshire and York, and then Humber, which covers the South Bank. So we want to continue to develop those and develop them as integrated care partnerships. So slight change of language. We mentioned acronyms earlier on, slight change in language, And what we need to do then is see how do they fit with the new devolved commissioning arrangements that's going to happen with integrated care systems and place. And if that wasn't complicated enough, we then got to look at provider collaboration, because there is a move away from tendering every service to look at how providers can collaborate better. And we're in a really good, we've got really good examples of that as an organisation, being some of the lead provider that we're doing for perinatal services, and a lot of the work that we've done in mental health, where we actually lead provide it, but we work with other colleagues to provide it, be the independent sector, the KICs or charities, etc. So we've got some grounding in that, but we need to widen that to the whole of the provider sector. That includes acute care as well as community. And I've been asked by the integrated care system and Steve and the independent chair to lead that on behalf of Humber, Coast and Vale. So we're building on what's happening in relationship to the mental health and learning disability partnership, and saying how can we develop that provider collaboration across the integrated care system, and then how does it link into, probably horizontally, into the developing systems, the integrated care partnerships. So I think I'll stop there. I could go on. It's a very whistle-stop tour, Chair, and just appreciate I've been talking for a while. I'm sure there's questions, but I think if we do a development session at some point with what's happening in the integrated care session, that might be better, and we can have a bit more of a detail on it. But I'll pause there for breath and for questions.
Thanks, Michelle. There is an awful lot going on, so thank you for that update. Yeah, I think we'll take that as an action, Jenny, to do that at a future development day. Are there any questions, comments? Oh. Doff?
I'd like to, Michelle mentioned in her report about Whitby, and I would like to say how fantastic the staff have been in really pushing that out and moving it forward. And I'm really, really excited about how that's going. So thank you to all the people involved and the trust.
No, thanks for your support as well, Doff. There's a little bit in my report about that, and the development obviously continues, but thank you. Yeah, we'll pass that on.
No, and as Michelle said, Doff, thank you, because I know you've been doing a lot as well. So yeah, and all these groups and everything else. So your time's appreciated as well. Paul?
Thanks, Sharon. Yeah, just to say congratulations on another excellent report. I suppose just one sort of side question is on 4.22, the COVID outbreaks point. I'm noting that Health and Safety Executive are taking interest on transmissible infections in the workplace. Has the Trust seen any sort of interest from HSC at all in that area?
No, we've done that. I mean, I'm sure I'll pick a lot of that. I mean, actually, as of today, we've got no COVID positive patients, which is great. And our COVID level for staff has been really, really constant. Staff have actually been very good in relationship to PPE. So neither the CQC or the Health and Safety Executive have had any issues with us at all, Paul.
Congratulations on a good education programme. Well done.
Thanks, Paul. Is there anything else before we move on? No, I think there's some comments in the box about the vaccines, Michelle, and some comments from some of the staff governors about how impressed they've been with the process. So I'm sure we'll pass that back to John and the team. That, to be fair, that's what we're hearing direct, all of us, I think, as we're out and about in the Trust virtually and otherwise. So thank you very much for that. So thank you for that, Michelle. As you said, we've got a full COVID update that Lynn's doing later. So if we move on to item 8, which is the public Trust board minutes are there for information. If you've got any questions, let me know. No, thank you. So Lynn, can we move to you then? And Michelle's done a very nice introduction for you to the COVID update. Thank you very much for your paper.
Thank you, Chair. Yes, and as you've already said, we have touched on a number of the issues already. So I will try to do COVID as a bit of a whistle-stop tour, so and just take you through the paper. So I guess, as everybody perhaps already has commented, really, that, and I would echo it as well, that I have to say our staff have been absolutely amazing through this process, and we wouldn't be in the reasonably good place that we are in, you know, without their efforts. And just when I think we can't ask any more of them, we've needed to, and they have stepped up and delivered. So, and as Michelle has said, that's right across the board. It's not just our clinical staff who have been great, but our corporate staff as well. We wouldn't have been able to have done this without them. And obviously it's not over yet by any means either, but just to predicate my report on that really important point too. And you know, Michelle touched on our volunteers, you know, who we have come back to time and time again to support us, and again they have just stepped up every time, so appreciate that. Otherwise, just taking you through the paper, obviously we are guided primarily in terms of our COVID response in relation to the information and the guidances that we receive from the national team, from the regional teams. Obviously, we're really connected in, as you would expect us to be, in relation to the emergency planning arrangements. So obviously, right through this pandemic since March, we've had our internal emergency planning procedure in place, overseen by our gold, our silver and our bronze command arrangements. We connect right across the system in terms of those emergency planning arrangements too. So obviously we connect into the local resilience forums in a variety of different ways. So obviously receive, you know, very much sort of, you know, large volumes of information right through this process. That's been a tall order in its own right, sort of managing all of that, but I think we've now got really great systems in place to respond to all of that. So at the top of the paper, just by way of information, I've obviously sort of set out the sort of current priorities from NHSE, as you can see there, that from December onwards, the key message obviously is to continue to respond to the ongoing COVID-19 demand through the health service, that we need to pull out all the stops to implement the COVID-19 vaccine programme, which I think we can quite justly say that we have certainly done that and will continue to do so. Real emphasis as well on not just maximising capacity to treat COVID patients, but also to make sure that we're continuing to focus on those areas, obviously responding to the needs of non-COVID patients. Now, obviously, it's very fair to say for those of you, and I'm sure we all are, sort of understanding the pressures, particularly in the south at the moment, that there is some prioritisation now taking place around sort of responding to urgent and emergency need, given the pressures there. But as Michelle said, actually we've managed so far primarily with maintaining all of our clinical activity right across all of our services. So we have had some short periods of time, and they have been short, where we've needed to implement our business continuity plans, but I'll come back to a little bit of that. Obviously responding to other emergency demands, particularly managing the normal winter pressures. And it's interesting, here I am sat today with a lot of very bad weather around me. So just to make this pandemic, you know, even more sort of challenging for us right now. And obviously a really important priority that we've already touched on today, that's recognised, you know, by ourselves, and we've got a lot of ongoing work around staff health and wellbeing, but obviously that's recognised nationally as well, that the only way we're going to manage this well is really to support our staff and their health and wellbeing needs as well. So obviously we've taken all of that into account in our planning, and that's reflected in all of the work that we do. Obviously on a local basis, as the paper sets out, you know, this pandemic obviously is predicated in terms of its demands around sort of what the infection rate is doing. So obviously we have mechanisms in place where we make sure that we're very well aware of that. As you'll be aware, we've got a position right now where just before Christmas, back end of October and November, we had a surge in the pandemic, particularly in Hull. In fact, for a little while, Hull was top of the chart, unfortunately, in terms of rate of infection. That has reduced significantly, interestingly. So Hull and East Riding at the moment are a little bit of an outlier. We've got some of the lowest rates at the minute. However, that is rising, unfortunately. So there has been some increase since I wrote this paper last week. We've got higher pressures in North Yorkshire and York at the moment, impacting on our services particularly in Scarborough, Rydale and Whitby to an extent. Some of you may be aware that the infection rates in York are particularly high. What we know that they're seeing there is the new variant as well. And obviously all the evidence is the new variant is more contagious. And that's certainly what they're seeing. So our work there is really on supporting, protecting the beds in the acute hospitals. So our community services really focused on supporting hospital discharges. I have to say those teams are working really hard at the moment. They are succeeded in doing that, but obviously that pressure is still rising right now. So we do expect there to be a third surge on the Hull and East Riding patch. We're expecting that to happen over the next sort of 10 days. Obviously, that's a consequence of people coming together at Christmas as well. Obviously, there's a delay in the infection rate increasing. So we're still anticipating that and planning for that. I guess we're really confident overall that through that second wave that we saw back in November and October, that really gave us an opportunity to test our emergency planning arrangements. Although they'd already been tested, I think, in the first wave, really around sort of our business continuity plans and were they robust. As the paper sets out, obviously one of the key issues in terms of maintaining our services, obviously, is our staff availability. So we obviously manage the position around our staffing on a daily basis. We understand the detail of that. We know where we've got staff absences. So I've obviously put the chart in there that sort of tracks the COVID-related absence right back from March until now. Unfortunately, it's also risen a little bit since this chart was produced as well. So I think we are seeing sort of that incremental rise as a consequence of the overall position around sort of infection rates at the moment. Other than that, really, as the paper sort of sets out, our operational pressures certainly did rise in that October-November position, as we've already touched on, really, where we saw those pressures largely. Certainly we're in those community physical services, district nursing teams in Scarborough, Rydale and Whitby as a consequence of their sort of support to the whole system, but particularly discharges from acute hospitals. We also continue to see pressure on our mental health services, particularly our crisis services. So our crisis team is continuing to see high levels of demand. Not only is there high levels of demand and referrals, but the acuity, the level of need that we're seeing across those patient groups continues to be very high as well. Obviously, we have maintained all of our infection control arrangements. We've already touched on, Michelle's already said it, that whilst we did see a rise in the number of COVID positive patients through October and November, that has reduced to the position that we've actually got no COVID positive patients today. We did have one yesterday, but even that service user has been transferred out of the cohort ward. So I do think that that is testimony to the fact that our staff, despite their sort of fatigue and tiredness, and they are fatigued and tired, however, they're not giving up. They are following all the guidances still. And I know from other mental health trust colleagues elsewhere on our patch, they still do have reasonably high numbers of COVID positive patients and some outbreaks. So we don't have any outbreaks, as already been said currently. So our operational pressures obviously continue to be higher than they ordinarily would be for this time of year. One of the impacts that we have, unfortunately, is an increase in the number of mental health service users in out of area beds. Now, we've had to reduce our beds to manage the infection control guidance around isolation, the COVID safe working, and having an ability to cohort COVID positive service users. So we have had to reduce the number of beds overall to address that. So to mitigate that, we have actually temporarily made arrangements with the some independent sector providers around out of area beds. So that means we're working with providers that we're very well used to working with. So we do have a number of patients at the minute, but we're managing that, making sure they're repatriated to local beds as quickly as possible. And interestingly, that bed demand, when I compare to winter last year, we're not actually using more beds overall than we were this time last year. So given those pressures, I think that's really sort of quite an impressive position really overall, but we continue to monitor it very closely, obviously very well aware of impact and safety in relation to that. So our view is that we prepared really well as well. Obviously the NHS is in its highest alert level, as you would expect. So obviously the new tier 4 level was introduced, and obviously the current national lockdown arrangements. So we anticipated those, we planned well for those. Particular areas that we focus on, particularly around sort of inpatient visiting arrangements, the leave arrangements, particularly for our mental health patients, and obviously our overall activity, and then obviously thinking about remote working. So obviously we're still in a position where those staff that can work remotely and from home do continue to do so, obviously in our efforts to keep everybody safe and able to work. We've touched on the testing arrangements. Obviously we have regimes in place to test our patients and our staff. So with the additional lateral flow testing, we really feel that that has been advantageous to us. Our staff are really positive about it. And as Michelle's already said, we were in a position where we rolled that out before any of the other mental health trusts actually in our patch, which was good news. And again, I think it just gives that sort of sense of control that people are testing themselves a couple of times a week. We don't have any particular issues at the moment with sort of school closures, but obviously a lot of our staff are parents. We are in lockdown arrangements again at the moment. Our staff are critical workers, so their children within the guidelines can continue to attend school. There has been some pressures experienced by schools, we know that, but at the minute that's not impacting on our staff obviously in attendance at work, so that's good news. I won't go through the vaccine, obviously Michelle's touched on that. And we've got good, robust arrangements in place now to manage PPE, so we haven't had any issues over recent months with any shortfall or supply of PPE, but obviously we keep that under close review. We had already put in place obviously arrangements to meet the requirements around COVID safe working. Obviously that does mean that, you know, as touched on already, staff working remotely, but obviously we can't see some of our patients face to face in the way that we were prior to COVID. Because of the safe working arrangements, we simply don't have the space now to do that anyway. So obviously we have adjusted our ways of working to address that. We have a clinical group in place as well. So that oversees all of the new clinical guidelines we get. So senior clinicians come together to have a look at those and obviously make sure that where needed, we make those adjustments to our clinical pathways and that that's communicated effectively to our staff. Our significant risk on our risk register at the moment, one we've already touched on, is the impact of working with these constant pressures through the pandemic on staff, fatigue, anxiety, and obviously again, really sort of indicating why it's so important that we've already put a lot of measures in place to support our staff health and well-being. I know a lot of those have been received positively, but we continue to work very actively around what else we can do to support that. So Sharon, I'll stop there, as an element of the paper is really around sort of planning and where we are in relation to that. Obviously, we've had to submit plans, as you would expect, to the ICS, to the centre, around sort of our activities, what we're going to be focusing on for the remainder of the year too. So hopefully that gives you a bit of a whistle-stop tour, but happy to take any questions.
Thanks very much, Len, for that very useful and comprehensive report. I'll go to Ros first, please.
Yes, very comprehensive. In fact, I hate to think the man hours and number of bodies that's been involved in this. Just looking at the conversion of the lecture theatre, I gather Hart Hill are using the facility for some of their patients for their vaccinations. I thought there was going down to Halton Price Leisure Centre to do that, but maybe that's something you're not aware of, but I think there might be a bit of confusion on that. But anybody coming up, any Joe Public coming up for their vaccinations, what are they doing about parking fees?
We aren't, Shazza. I mean, I think that was the PCN that I referred to. We have supported Hart Hill PCN last week. We did all their patients, and that's if they've got the offer for next week. And we haven't been charging for parking at all since last February, March time when the pandemic started. And we will continue with that throughout.
Lovely. Thank you very much indeed. Thanks.
Sorry, Len.
The PCN, Roz, are absolutely delighted with us. So there were other options looked at in terms of site for that PCN to deliver its vaccine from, but actually the lecture theatre was already ready to go, and they are nothing but delighted with how it's worked for them.
Good. I expected nothing less. Well done.
Thanks, Ros. And we did send around the video of the conversion of the lecture theatre to the governors, but Michelle's suggestion is probably sending around some of the more recent videos that have been done might be a good idea as well. So we'll do that as well, Jenny, after the meeting. Doff?
I just want to say that Paul McCourt seemed to have got locked out of the meeting, and he's trying to get in.
Yeah.
I keep trying to admit him, but he keeps failing, Doff. I am on the case. I think he must have a bad signal, because I keep pressing the tick button, but he hasn't made it back in yet. So I'll keep trying.
So in response to Lynn's report, which I found absolutely interesting, and it's fascinating to really hear about the detail of what's been going on. I'm kind of interested in what the worst case scenario looks like, and I don't know why I'm interested in that, but I'd like to think I know that we know when we're hitting the boundaries of what we're doing. I'm particularly interested, and I've got a question that I want to ask later on in the meeting about stepping up and stepping down the capacity of the normal services, because to be able to cope with all of the COVID stresses, although it says maximising capacity in all settings to treat non-COVID patients, there must, given what we have a great concern about the staff, but there must also be a great concern about the patients that potentially we're not seeing, and what that backlog, which is later on in the meeting, I think there'll be an opportunity for me to ask a question about how we're actually looking at preparing for that backlog that's at this moment in time.
Shall I start that one off, Lynn, and then shall I start that off from a strategic point of view, and I'll come in, because I think we touched on a little bit of this stuff in my report in relationship to we haven't stopped any of our services at all. We've changed some of the service delivery methods, so gone on to non-face-to-face, etc. And actually, we've actually one of the first trusts in the country to do a randomised control study on that. Has actually had some really positive outcomes, that actually patients find them more useful in the main. So we have altered some of the ways that we've delivered services, but we haven't actually stopped any of the services. What we are noticing is an increase in demand. Now, there was a slight reduction in demand during the first wave, which was the same across all the areas, and we didn't know whether that was due to a bit about confidence in the system, people really, religiously living to the lockdown, the first lockdown, etc. And obviously since then it's been a gradual increase, and partly with acuity, and we don't know whether that acuity is coming from relationships within CMHTs, whether it's coming from PCNs, primary care, or whether it's due to furloughed charity staff, or a mixture. So from a strategic point of view, we're doing a big piece of work on the acuity levels across the system. As an organisation, we've done shed loads of work on demand and trajectories in demand as we get into a point of recover and restore. And we will continue to do that. The trajectories are there that we're working to, and we've fed those into the wider system as well. What we've done is work really closely to pick up your point. What does the worst case scenario look like? I think one of the reasons why we hopefully have been ahead of the curve on this is we have worked backwards from what is our worst case business continuity plan, and work backwards from that. And as Lynn said, the weather hasn't helped, but it is a part of our normal winter planning. So that has gone into that, and we've worked on position of 25%, 30% less staff, etc. But what we have done is work really closely with other organisations from a mutual support and a mutual aid point of view. And as Lynn mentioned, we've been sharing supplies that we're going to do other people's vaccines, etc., etc. And that includes primary care, because primary care are a really important partner. But more importantly, and we were the system that led this. We've done some work with the military about the logistics of demand, etc., which has proved to be very helpful, and we've got plans for that. But we've also developed a surge plan. So we've got our own internal surge plan, which means if we get real peaks of real difficult business continuity, you go into what's called a surge mode, which the NHS is probably in that to some extent at the moment. But we've also done that with our mental health, particularly mental health providers. So we've now got a surge plan for all the mental health providers across Humber Coast and Vale, so that we can utilise the maximum services that we've got across the system. What we haven't done as much of is the same for community, because as you know, we look after quite strongly the community in the North, Yorkshire and York piece, but not necessarily in Hull. But as far as I say that, Lynn and the team and the work that we've done with the local authority and the system in North Yorkshire and York and the hospitals and the model that we've got is proving to be really, really successful. It is challenged because there's a lot of discharges coming through, but we've also, as I alluded to in my report, stood down, relaxed a little bit of some of the governance stuff and processes that we're doing to allow the freeing up of our clinical staff that are in corporate services to be available to work in clinical services. And we have mobilised clinical services from certain services, like from commuter into acute if we need to. So there is that flexibility, and that comes back to staff just being fantastic and being really, really supportive. The two things that we've had all the way through this have been patient care and safety first, and that's been underpinned everything that we've done. And the second facet that we've been absolutely obsessed with is staff health and wellbeing, which is why we've put a lot of services in there for staff health and wellbeing. And you just have to look at the health and wellbeing hub that we've got on our intranet to see the plethora of things that we have and will continue to do, and we'll continue to ask staff and we'll continue to increase that as we go through. And there's now a resilience hub as well on top of that for the system that I've developed for the system, that is in addition to health services and social services staff own organisational offer. Lynn, that's just a strategic view. Is there anything else you want to add to that?
No, Doc, I hope that answers your question. But as Michelle said, I think we've got a lot of internal planning. So we have planned up to, and actually beyond 30% staff absence. So if you go back to my chart in my paper, when we were at the highest level in that second surge, November to October to November, we had a day when we just got over 10% overall absence. But that's the highest we've ever been at so far. So I think the fact that we chose sort of 30 to 35% as our threshold, I would hope that is as far as we will get. But we have developed that super surge plan, not just our own, as Michelle says, but we've led that across the system too. I hope there weren't too many acronyms in my report, but you can let me know.
Thank you very much. That's really, really helpful. And I'm very impressed with everything that you're doing. Thank you.
No, thank you very much, both of you, for that response, and thanks, Don, for the question. So come to Anne next, please.
Hi, everybody. Just a quick one. It was really just some positive feedback about the vaccines. I think a lot of the back office staff weren't necessarily expecting to be included as part of the vaccine rollout. And it was just to say, I think if there was ever an effort in PR to engage with staff and make them feel valued, you did that in one go. And I think it's been really positively received that everyone is valued exactly the same way. I also wanted to say, I feel like it's like compliment session here, but may as well go with it. I don't have any questions.
Don't apologise for that, Anne. Don't apologise for giving compliments.
Just to inflate your egos a little bit more, I also think the Q&A sessions that have been done
I think you've jinxed it for yourself now, Anne, because we can't hear you.
Just you just hold in the compliment, and you cut off.
We got as far as the Q&A, and that was then you stopped.
Oh, this is having children, homeschooling, and Xboxes, and it was really to say that I think as much as COVID presents so many difficulties, the Q&As that you're doing are engaging with vast communities across the trust. So I pop into as many as I can, and there are, I know it's not massive numbers, but there are in excess of 150 staff attending these calls, and it's definitely changing the reach and availability and the perception, I think, of the hierarchy. So hats off to you for that. And finally, just to inflate Michelle's ego a little bit more, she dropped in on an event we did recently and was very candid on the call about, you know, her own personal experience during the COVID experience for us all. And I think all of this makes everybody a little bit more human. And I genuinely think people, as tired as they are, they're keeping going because what's happening around them is everybody's collectively engaged and trying their best. Whether we're hitting all the marks, and I'm not even in a hub. I'm working at home. I still feel people are up as much as they can be, are positive, and I feel like they're being looked after. That would be my observation. I don't know whether Mandy or Jack or anyone else can comment otherwise, but that's just to say thank you. End of.
That's
yeah,
great.
I'll endorse that, Anne. Everything you said, absolutely 100%. Very proud to work for the organisation.
No, that's great. Thank you both for that feedback. Thank you, Anne. Don't ever apologise for giving a compliment. That's really good. Anything for anybody else before we move on? No, thank you all very much for that. So, well, we wouldn't like to not mention the other hot topic, probably not as hot topic as COVID, but Pete, Brexit.
Yeah, thanks, Sharon. It might be a bit of a tough act to follow, so maybe we need to think about the agenda staging next time just a little bit. But just in terms of Brexit, I'm the Trust SRO for Brexit. I have been for the last 2 years, and at the start of what feels like a very long journey, we did establish a Brexit group, and we've continued to meet on a regular basis. Within that group, we have probably 7 areas of focus which came down from the national guidance, and we have operational leads for each, which you'll see in the paper. Actually, the group met last week, so we thought it would be timely to meet just after the exit, and you know, I guess I'm going to use the word proud or pleased to say that nothing was escalated at that meeting, and we're continuing to operate as much as we can as business as usual in what is an unusual world at the moment. And as a group, we agreed we'd continue to meet till at least the end of February, just to keep a watching brief. You'll see from the paper that there was a national approach to the security of supply, which I think was everybody's nervousness, and that was multi-layered, with suppliers being asked to hold 6 weeks worth of supply, national buffer stocks being established, and priority freight routes being established, particularly for medicines. A couple of other bits shown, and then I'll just stop for questions. So within the trust, we've got approximately 30 EU nationals, and we've been supporting them since the start of this with applications for settled status. Pleased to say 10 have already applied, and we're supporting the rest, and we have until the end of June to apply for this. And I guess very last minute, a deal was agreed by the government with the EU, which got voted through a couple of weeks ago. A couple of highlights from that deal for me, where it's 0 tariff, but we are expecting customs checks. So there was a view from the national team that that might impact on maybe 2 to 3 days worth of delay in supply chain. So the buffer stocks should give security of supply. And also there was a reciprocal healthcare agreement. So anybody who's got an EHIC, your EHIC, if I can get my words out, is still valid. But when that does run out, it will be replaced with a GHIC, so a global health insurance card. And I think if I stop there, you know, the details in the report, and I'm happy to take any questions. Oh,
well, there you go. Sorry, there you go, Dos, some new acronyms for us for the G and the E. And an SRO is Senior Responsible Officer, just for those. It is mentioned in the paper, to be fair to Pete. So any questions for Pete on the Brexit paper? No, thanks, Pete and the team, because I mean, it has been a long running and a lot of work done to ensure that everything's okay. And as you say, still possibly not over yet in terms of the monitoring briefing going forward. So thank you for that. So if we stay with you, Pete, we've got a run of your papers now. So the first one is the performance update, please.
Yeah, so usual report, Chair, you know, performance as at the end of November. Continuing to use statistical process charts, and I note from earlier that we have got the development session coming up where we'll do a bit of a run through how SPCs are formed and how they work. You'll notice from the charts that we have shaded when the COVID pandemic started, just so we can see if it has had any influence on our underlying performance. And we'll see from the front sheet, we've included some commentary on any of those indicators that fall out of what we call normal variation. So I think if I stop there, it's best served going straight to questions, Chair.
Thanks, Pete. Questions on the performance report for Pete?
Yeah.
Tim?
Thanks. First of all, page 28, and I may have missed this before, but this is about the complaints. It does say in the heading, 2 charts showing the number of complaints received and the number of complaints responded to. And all we seem to have got, or at least all I've got, is 1 chart, which is the complaints responded to and upheld. It may be that I've overlooked the fact that they've not been supplied before, but we seem to be missing a page. Is that right?
I think I'll just give Pete time to find it, but I think the both lines are on the same chart, so it might be the narrative that's wrong.
Well, one says one of those says responded to, and the other says sort of updated, upheld, those upheld. So I don't think that's right.
Okay.
But Pete will be able to look at that.
I think you're right, Sharon. I think the 2 lines are showing the number of the number of complaints responded to in month, and the purple line underneath is the number of complaints that were responded to in month that were upheld. So maybe, just reading it, Tim, perhaps the legend could be better described.
It does say showing the number of complaints received, and we don't have it.
Sorry, sorry, Tim, I misheard your first question. You're absolutely right. Received isn't shown on the chat.
No, so for another time, and obviously these come to your board as well, another time that needs to be included, doesn't it? But that was just one of the things. I'll leave you to drop that down. The other was, I mean, I'm pleased what Lynn said, because I was going to raise about out of area placements, but she's given the answer to that and why they've arisen. But on page 11 is the goal 2, and that is the number of follow-up within 72 hours of discharge in the CPA 7 days. Those figures are not good, and that I think is possibly going to also relate to your next report, which I shall come to when you present that. But those are not looking good, are they? That is the 72-hour follow-up. More particularly, the CPA 7-day follow-up is a big drop.
Lynn, do you want to just respond to that while I find it, please? Do you want to start with the 72-hour follow-up, which is at 83.3, I think, and the target's 80. It's page 11 of the report. That might not help you much.
Right, yeah. I mean, that isn't so bad, although it's on a downward tip, but it's not too bad. It's the other one, which is the CPA follow-up, which is really dropping. Even since COVID, it's maintained a good level. Now it's suddenly really dropped in November. I don't know what the latest will be.
Sorry, I am just
Page 94 then.
94, thank you. Just getting there. Yeah, so I guess from our point of view, yes, it is slightly lower, but it's still within normal variation. So from an SPC point of view, so if you look at the chart overall, so at this point in time, it's still above the target. So we would want it to be closer to 100%. Sorry, it's a bit below, but this is certainly something that we monitor on a daily basis as it stands. So, you know, my expectation is that, you know, it will, you know, be maintained overall at the target levels. So obviously there are some times where it's affected by the number of discharges we have in month as well. But obviously, you know, yes, you're absolutely right. It has dropped in that month, but overall, you know, we have maintained it at, you know, through the COVID period. So, but it is, I can assure you, it's monitored every day, this target.
Yeah, I accept what you say about it monitored. It's done well during the COVID period. I mean,
yes.
Actually better than in some ways before. It's just simply the sudden drop, that I was concerned about. And my concern is these are the figures for November. We're January now, and I'm just wondering whether it's dropping even further and faster.
Give me a minute, I will come back and I'll drop it into the chat box around what the
Okay.
latest position is.
Thank you. I've nothing further on that. Thank you very much, Chair.
Thanks, Tim, for those questions, and Lynn will just update the figures if we just give her a minute. Is there anything else on the performance report? Paul?
The connection problems. Page 15 on poll. Will give people a chance to get to it.
Is the 52-week waits, is it?
52-week waits, yes. So the conversation that the governor's had sort of prior to the meeting, and one of the factors involved in, in the direction, it would appear that the trust had turned the corner, was driving those numbers down. It looks like COVID is one of the key factors there, but I suppose it's just really looking for an explanation from Lynn as to what's impacting on those figures.
Yeah, no, definitely, Paul. So I can absolutely assure you, the main areas where we've got waiting times are in our children's services. They are specifically for autism and ADHD diagnosis. So the first thing I would say, that doesn't mean to say that we are actually not in very active contact with these children and their families. The clock stops when a diagnosis is reached. And quite often we've had a lot of contact before we get to that point. We had pressures in these waiting times before COVID in March. We were already in a position where we were working hard around those, but particularly for the autism diagnosis, one of the key elements in the pathway is what's called collateral information that we receive from education services. So obviously when schools closed in the first wave, then that meant that we weren't able to progress that in the way that we would needed to have done. Obviously schools did reopen, and then we picked up the pace again around the waiting times, which is why it was improving. Unfortunately now, obviously with another position where schools are closed, that's having impact, as did that second wave as well, unfortunately, back in October and November. So we're very focused on this. We've got trajectories, improvement plans in place to address this. So I'm really hopeful and optimistic that those plans are robust. But we do need, for that particular element of the waiting times, for schools really to be accessible in order to reach, because obviously we want to reach safe diagnosis. Now we have everywhere along that pathway thought about how we sort of use remote digital options, and they are in place, I can assure you, but it is an ongoing area of focus, absolutely. Some of our other waiting times have actually improved overall. We did have a waiting time issue around sort of access to the general CAMS service, core CAMS as we describe it. That's actually improved overall, but it is the autism and ADHD element. And obviously we're very worried about those children because often they have particular issues, particularly families in lockdown with those issues too. But I can assure you we are in contact and we are prioritising.
Thank you. So that sounds like there are factors there that are out of your control, really, that you are relying on other agencies to play their part.
And obviously it is a whole system issue, Paul. So there's an incredible amount of system work, particularly with the local authority, with CCGs around, how we work collectively together to improve this. But it's not a position that any of us wants to, see deteriorate, unfortunately. But within the constraints, I'm afraid there is some impact, particularly from COVID, on this cohort of service users.
Thank you.
Thanks, an important question. Anything else on the performance report? No, I think there have been some good questions there. And Tim, Pete's put something in the chat box about CPA and the performance has recovered at the previous levels for CPA in December's report of performance. And we'll get back to you. Pete will get back to us on the first question you raised about number of complaints.
Thank you.
Thank you all very much. If we could move on to item 12, which is the finance report, Pete.
Thank you, Sharon. So this is the finance report up to the end of month 8 or November, but the paper covers the 3 months within the reporting period since the last Council of Governors. I think it's important to note within the paper that we still continue to operate with a block income allocation, so the normal contracting arrangements we've operated in for a number of years are still suspended whilst we're in the COVID pandemic response. Some of the highlights I would pull from the paper are, we've continued to record a break-even position at the end of month 8, and that is what we're being asked to do. You'll note from the position that, to the end of November, there was 10.4 million of COVID costs, which for month 1 to 6, that was claimed retrospectively by the trust, and I can now give you an assurance that all of those claims have been approved and reimbursed. And then for the second half of the year, we received an allocation to cover our COVID cost of just shy of £5 million. You'll note from the report that cash in bank at the end of the month was 29.8 million. This did include 1 month block funding where we've been paid in ahead, and again, that was part of the national response to the pandemic and to ensure cash was flowing through the system and to providers. But once you strip that 9.8 million out, we still remain in a strong cash position. I think if I stop there, Chair, and I'm happy to go to questions or take any questions.
Thanks very much, Pete. Tim?
Thanks, Pete. I'm sorry, both on my last question about complaints and something I'm going to say on paragraph 2.4, corporate services expenditure. It sounds as if I'm ambushing you, and I didn't mean to, because this is going to require you to quickly look at some figures in 2.5, the corporate services expenditure. I only got to the calculations last night. I can't make your figures add up in 2.5, and I'm wondering if there's a typing mistake in the provision, the contingency, where you put 0.5 million and there's a sort of a 1 after that with a comma, because the figures, when you just look at them and work on them, they just don't, it doesn't come to what you're saying about there's an underspend of £50,000. I can't expect you to respond to that at this moment, but if you could look at that, because I just, whatever I do, I just can't make it work out. I think there's a typo somewhere. My point that I do want you to address, though, please, is this. The underspend on the mental health services, whatever it be, the community, primary care, children learning disability, so on, is over £2 million. What are the factors involved for that underspend? Because we're primarily, if you like, a mental health trust, and we've got this really large underspend. If I can just comment, I'm not so worried about the amount of money we've got in the bank and so on. It's the fact that when you set the budget, you balance the budget against what you knew you were likely to have and so on, and yet we've got already a 2 million underspend. So what are the factors for that underspend, please?
So 2 main factors for that underspend, Tim. The most significant factor is the community mental health team pilot. So as a trust 2 years ago, we were successful in a bid for community mental health team transformation funding. We get an allocation year on year of £4 million for that project. We have been recruiting up to that project, but I think it's fair to say, and probably impacted on COVID to some degree, the recruitment hasn't gone as quickly as profiled. So that is why year to date, we are reporting an underspend, particularly in mental health services, but we have been providing assurances, and I'm sure Lynn will come in on this one. We've put additional resources into that project currently to speed up and enhance the recruitment, and we expect to be as close to fully established by the end of the financial year.
Yeah.
Thanks, Lynn. Lynn, I know. Sorry.
The other things.
The other ones will just be general underspends on the level of vacancies we've got in. We are up to recruitment when we're not deliberately holding back any recruitment, but we've just had some underspends because we've had vacancies.
So it is to do with recruitment of staff?
I come in there, Chair? Is that okay?
Yes, of course, Michelle.
I mean, just to reiterate from a systems point of view, what Pete said about community mental health teams, there was a £2 million lag in relationship to that last year, actually, and we've been working very closely with our partners, because it's not just a Humber FT issue, it's an ICS system point of view. So we've been working through that. So all the money is now accounted for, which is good. But as an organisation, and I suppose a bit of challenge back, Tim, apologies, but we are an integrated combined trust, so we have got an extensive level of community services as well across the patch. So you'll notice through most of it, we do not carry underspends in clinical areas. We've got a budget reduction strategy that we do every year, but we're not an organisation that will withhold posts in order to balance, as it were. So our vacancies are due to recruitment and ongoing recruitment, but if you can see, they'll also be offset about utilisation of bank and agency staff as well. So we're not an organisation that will pull clinical posts or hold back clinical posts in order to maintain a budget position.
No, you and I have said, I think that's been mentioned to me before, and I accept that. But it's simply wanting to try and understand what the factors were for the underspend, and it does seem to be possibly, as much as anything, the difficulties in recruitment and and therefore the training. But you'll appreciate that it is quite a large underspend, and it does balance the books as it so happens. Pete, thank you, Michelle. Pete, I don't know whether you've had the chance yet to look at 2.5, and do you understand what I was saying, that the figures don't seem to add? Is it a typo or what?
Yeah, I've read 2.5, and I think, Tim, that's probably clumsily written. What we're trying to say on 2.5 is the total overspend on corporate services, when you look at Appendix A, is 1.543 million.
Yeah.
Exclude the finance technical line, which is 1.594 million, of which an element is the BRS, which is referred to in the text.
Yeah.
That's when you get to your 50,000 underspend. So I guess we've got, dare I say it, because I'm living and breathing this day in, day out, you get not number blind, you get comfortable and understand the numbers, but just reading it back now, understand why it could have confused.
Yeah, so really we needed the figure of 1.594 in that in the description as much as anything, wasn't it? Probably that would have helped, and that would have made more sense. But anyway, thank you. Yeah.
Thanks, Tim. Lynn, is there anything you wanted to add, particularly on the community mental health? Don't feel you need to, but if there's anything you want to add.
No, it's just to endorse what Pete said. The other thing that happened is that programme was actually paused nationally from April to July. So we didn't pause the whole programme for that length of time, but we did pause it in the very first couple of months or so of COVID. So that did put back the recruitment as well. So, but we have done an immense amount of work. In fact, we've had really positive response to recruitment now. And as Pete's already said, we have a real plan in place to recover that position by the end of the year.
Thanks. I'll come to Francis in a minute because he chairs the Finance Committee, Tim. But just as a bit of a suggestion, it's a fair question, Tim, and it's a good question to ask when you see the figures. I know this has been discussed before, and I know Lynn's responded to the governors, and I think it was raised probably at the last not the last governor group, but the one with the last focus on finance. Pete, could we just, on this particular issue, can we just, next finance paper that comes to the governors, could we just, if there's still an underspend, can we just specifically give an update on it? Just a couple of lines will do. But it is something that the governors have asked about before, and I know we've given the answer, but I think it would be helpful if you don't mind, because it'll be another quarter by then. If we could just have an update, that would be helpful if you don't mind.
Yeah, that's not a problem, Sharon.
Thank you. As I say, a couple of lines is fine, but just we'll know where it is, because to be fair to Tim, it's a fair question looking at the figures, but I know it's something that other governors have been interested in as well. So, Francis.
Thank you, Chair. Just to assure Tim, this is something that has been discussed repeatedly at Finance Committee, and then is cross-referenced at Workforce Committee. So both Peter Barron and myself keep a close eye on this, because the last thing we want is not to have enough staff within the trust both for patient safety and for staff morale, it's the wrong thing to do. So we keep on top of it, and we then discuss it. I sit on the workforce committee, and we discuss it there. And I know that Mike Cook also has the same kind of discussions at quality committee. So we do triangulate it between the three committees. And there is a huge amount of work going on, which I'm sure Dean could talk about with his chair's hat on, from the Unbelievable programme, which is really, really good. And we've seen some figures recently showing how well that whole programme is going. So just some assurance that with our NED hats on, the three committees do look at this quite closely at the meetings. In fact, we had a discussion about it in December at Finance Committee.
Thank you very much.
No, thank you. And Dean, I know we've had discussions about this, and we've linking with Steve about coming to a future development day, I think, aren't you, to update on Unbelievable, Proud, all those kind of things that the trust has been developing and investing in, as I think it'd be really good for the governors to have a bit of a flavour of how much has been going on in the background, which is good. Okay, Paul?
Thanks, Sharon. Forgive me, I've been dropping in and out. So this may have been covered by colleagues. Again, going back to sort of the governor's meeting beforehand, it was silly. I was silly enough to sum up a conversation and was tasked with asking a question, but I'm not going to put Peter on the spot. I suppose it just really ask that on our development sessions, I just ask if we talk through the concept and use of prudent minimum. That was quite a big discussion we had earlier on, possibly how that relates to the trust's current position and how reserves are an enabler for uplifting capacity, which I think we've already touched on in the earlier conversation.
Sorry, I missed some of that, Paul. Was it prudent minimum?
Yeah, if we could ask Peter to give an overview of prudent minimum
right,
reserves,
okay.
How that relates to the trust's current position, and how that relates to being an enabler for uplifting capacity, which I think is linked to the conversation we just had that I dropped in and out of.
Pete?
Does that make sense?
It does, Paul. I'm happy to cover that at the planned governor development session. I guess, without putting myself too much on the spot, and I know Michelle's put a hand up, technically, we're an FT that we're not technically supposed to have oodles of reserves. We get control totals that we report to, and we're kind of held accountable to each year. I think where we do create reserves, that's more through creativity as opposed to what's allowed under the national rules, if that makes sense.
Yes, it does.
Michelle?
Go into more detail session.
No, I think they're all good questions. I'm happy to look at it. It's a good question to ask about reserves. It's a good question to ask about underspends. It's about that reassurance that we're spending the money in the right area and on staffing. Just to sort of endorse what we've been saying in relationship to staffing, we are in the process of doing quite a detailed piece of work in the trust about our staffing levels, that builds on safe staffing reports and all the other work that you've seen, that will support our recruitment and retention plan, which is extensive. So we're constantly looking at that and the staffing profile and how we can maximise the functions and skills, etc., of staff. So we are on with that, both from a nursing point of view as well as from a healthcare support worker and others. And that will feed in Tim and others to the work that we've done in relationship to budgets. And that's been done by an external agency to give us a little bit of independency as well. So there'll be more on that later. It's just in process and train at the moment. But we do want to keep revising our levels to make sure that we've got the right staff in the right place with the right skills, and then adjust our budgets accordingly.
Thanks, Pete.
I think it was just to probably cover the point that Michelle's just made, and I guess the other point I would have made supporting the earlier conversation is the actual amount of staff we've got in the trust at the moment is probably increased and more than we've had in previous years. So whilst we are carrying vacancies, but some of that is vacancies against new investments predominantly, where we've been successful in securing additional investment. But the actual physical headcount in the organisation, the last time I saw a report, it was higher than it had been.
Thanks, Pete. Can I just suggest, in terms of the questions on like the reserve questions and stuff, would it be appropriate to have this discussion at the governor group when the focus is on finance? rather than having a development session, because then those that are interested and we could coordinate with Hugh, who chairs that finance bit, in advance in terms of any questions from governors, Pete, going into it. And obviously you'll have the relevant non-execs there as well. So I think it might be just good to have that bit, you know, full discussion at that meeting if governors are agreeable. Hugh, is that all right with you?
It's fine with me. I think the people and things like that. I think at the governor group, it would be really good to understand, actually, and I think the other thing is just the ways in which we can.
I think we're losing you, Hugh, I'm afraid. Sorry, Hugh, the signal's not very good. Can I suggest that
how we can use that, just how we can use that investment potential would be really good.
Okay, well, can we have a conversation about the next, because it will be coming up, we'll know the date of it, the next governor focus on finance, and we'll try and coordinate in advance, Pete, so that we know what kind of questions the governors might have, and we can liaise with Francis and Peter Barron as well, which would be helpful, I think. But at least then it'll be a good frank discussion, won't it, that group, with enough time at that group to be able to have that discussion, if that's okay. Doff, you've got your hand up. I think you might be on mute, Doff.
Thank you very much. What I wanted to say very much fits with it would be good to have the opportunity to talk about it in the development session. In my previous life, I did work with South Tees Hospital as the voluntary sector to try and support stopping people from needing hospital services. And I just wonder, in our COVID recovery plan and looking at the increasing demand on mental health services, if there were the opportunity within this small amount of money to look at if we can commission are the effective ways the voluntary sector can support the trust more effectively. And it kind of addresses the fact that the voluntary sector are there and they can support the trust, and maybe in amongst all the things we're trying to do, we can just spend a bit of money to look at if we can make that more effective. But that's giving you some of the scope of what the discussion might be.
Okay, well, we'll coordinate questions through Hugh as chair, if that's all right, and I'll liaise with Hugh, and then we'll target most of them from what we've heard for discussion at the governor focus when it's on finance. But if some of them need to be somewhere else, then we'll have them somewhere else. But I'll coordinate them through Hugh, if that's all right, and then we can arrange that for the appropriate group. Okay, thank you all very much. Some really good questions and challenge there. So if we move on to item 13, which is the governor group's feedback, you've got the paper there. Do any of the chairs wish to add anything to their reports? No. Okay, you've got all the information there, and I think Katie will have circulated the up-to-date dates to you in the governor calendar, which we send all the way around, so that's good. And I know from meetings with some of the new governors that some of the new governors will be definitely interested in joining those groups, or at least trying the groups out to see which fits their areas of interest, so that's really good. So if we can move on to item 14, there were no responses, so there is no paper for that this month. And then to any other business, and I've just got one. Has anybody else got anything? Anne? Can I? Well, I'll tell you while I'm waiting for
London. Will you speak?
While I'm waiting for Anne, I'll just do mine then. Mine was it's Ros Jump's last meeting. And Ros has been a governor for a long time in various guises over the years and has contributed greatly to the Trust and to the Council of Governors, been an absolute active member of quite a lot of the governor groups over the years. And not only that, has given a lot of feedback from her constituencies in her other role as a councillor. So, Ros, I hate to embarrass you, but I would just like to say you will be missed. Thank you for everything you've done. I know your fellow governors will miss you, but on behalf of the board, thank you very much for everything you've done. We will all miss you too. Sure. And we look forward to continuing to work with you with your other hats on as an East Riding councillor and otherwise. But you've your big shoes to fill. So thank you very much. And I know that on behalf of everybody, you will be missed. So thank you very much.
Yeah, sure. Can I just thank you all? I continue to learn an awful lot all the time I've been here. I think I've known you, Sharon, since about 2007. And worked with the Trust in some shape or form since then. I have seen it develop most fantastically into the present situation where we now stand. And I think the board has just gone from strength to strength. Leadership has gone from strength to strength. And the change I've seen, I never thought I would see such a seismic improvement. So there's only one way up, and that's further up. So I shall follow developments with interest, but thank you very much. Bless you, thanks.
Thank you, and please do see the comments in the chat box, Ros, as well. Yeah, as I say, we have very much enjoyed working with you, and you're right, you and I go back to my PCT days when you were campaigning on behalf of community hospitals in those days. So yes, we go back a long way, and I'm sure our paths will cross as well continually. So thank you very much. So Anne, sorry, we lost you for a bit. I'll come back to you. What was your any other business? Oh, I think she's still frozen.
Oh, can you hear me?
We can. You're a bit intermittent, but go ahead.
Looks like she's frozen again.
No, I think you're frozen again, Anne. You might have to put it in the chat box or speak to me afterwards.
You have to get those kids off the Xbox.
I think she will.
The weather must be bad.
Well, I think unless has anybody else got any other areas, any other business? No. Can I thank you all? Anne? No, I think we're going to have to give it up. If it was anything particular, well, I'll catch up with Anne afterwards, and if need be, I'll circulate whatever she wanted to ask or say around the governors anyway, to make sure we don't lose that. But can I thank you all? I think it's been a really good meeting. Lots of good questions and lots of good challenges, some good actions agreed from it, and some good sessions planned. So thank you all very much. Stay safe and stay well. And Katie will have sent round the list, and please do get the dates in your diaries, and we look forward to seeing you at meetings very soon. So take care, everybody. Thank you all.
Bye. Bye-bye.